What data do you need to calculate quality measures?
Great question, Kyle. Let's start with a simple definition of healthcare quality measurement. It doesn't matter whether measuring for the merit-based incentive payment system, that is MIPS, the APM performance pathway, that's the new APP, the healthcare effectiveness data and information set, that's commonly known as HEDIS, or any other healthcare measurement set. Every quality measure is asking a variation on a single fundamental question. Have our patients received the health care we intend them to receive? Now, that care can be defined in terms of an outcome, like the level of blood pressure control or hemoglobin A1C, or it can be determined in terms of an intervention, like ACE inhibitors in our patients with left ventricular systolic dysfunction, or annual influenza vaccination for those who are eligible, or say a potassium level for patients on diuretics. There are other kinds of quality measures, but the most common we experience involve the relationship between two numbers, the numerator and the denominator. The denominator defines and counts for any given outcome or intervention the eligible instances in our practices for the outcome or intervention. Now, when I say instance, it could be patients eligible for a certain intervention, like women over 50 who might need a mammogram, or visits eligible for an intervention, like healthcare visits during which the level of pain was assessed. Now, the numerator defines and counts relative to each instance in the denominator those eligible instances who achieved the designated level of control or received the desired intervention. That typical quality measure is expressed as a fraction, the numerator over the denominator. The count of those who have achieved the outcome or received the intervention over or divided by the count of those eligible for the outcome or intervention. The denominator, the count of eligible instances, is literally the bottom-most number in the fraction and is also figuratively the foundation of the measure. We start with the denominator. The denominator comes first. We can't measure performance until we know which and how many patients or which and how many visits the measure applies to. Every measure has a set of measure specifications. Measure specifications should spell out, with no ambiguity, the eligibility or denominator specifications and the performance or numerator specifications. To the extent that there is ambiguity, it's not a good specification document.